All right. So we're going to get started. I do have some PowerPoint slides, so I'm going to go ahead and start sharing my screen, I think. Let's see. All right. So today I'm going to talk to you guys about managed care and a level of care primer. The real things that I want to accomplish is just to kind of give you a brief overview. A lot of these things you may already know. Some of these things I had no idea of even after practicing hospital medicine for 10 years. So hopefully it will be helpful to you. Um, for some of you, I know, some of you I don't know. I'm Dr. Washington. I am the physician advisor at St. Francis. And so what a physician advisor is I am a physician. I have a background in hospital medicine. I'm Med-Peds trained, but basically I review the cases and I review the cases for medical necessity, and I do most of the peer-to-peer reviews that the insurance company requires for the patients who are on the inpatient side of our facility. If they have to go to another facility like a rehab or something, usually the attendings do the peer-to-peer calls there. And then also there are a couple of the insurance companies that will only talk to the attending physician to do the peer-to-peer calls. So I don't have any disclosures at all. So as far as objectives, we are going to review the basics of health insurance, talk about the brief history of health insurance, talk about the different types of Medicare, talk about Medicaid, talk about managed care, discuss level of care, and then also the importance of clinical documentation improvement. So most people know what health insurance is. It is a product to cover your medical expenses. The thing that's important to know is that it doesn't cover 100% of your costs. Most of the time there is a deductible or co-payment or co-insurance that is associated with the insurance. And then there's also an out-of-pocket limit for the insured individual. We all have health insurance, and if we have medical conditions, then we would be very attuned to what those conditions are, what our deductibles and co-payments would be for various medical services that we might receive. So when we talk about the types of health insurance, there are several types. So you have the public health insurance, and that's the Medicare, Medicaid, and the Children's Health Insurance Program. You have private health insurance, and that can be insurance purchased by an individual or insurance purchased by the employer. And then there's also a short-term health insurance or gap coverage. So the thing to know is that the insurance that is purchased by the individual is usually more expensive than that which is purchased by the employer. So to just give you guys an example, as in one of my jobs, I was not considered an employee. I was considered an independent contractor. And so with that job, health insurance didn't come with it. So I had to purchase my health insurance individually. And the amount of money that I had to pay per month for my health insurance plan was about $600. So about $600 a month for that. And then there were also times where, say, I finished residency and I hadn't yet started my new job. I didn't want to have a time where I didn't have health insurance. So at that time, then I purchased a short-term health insurance or the gap coverage that they're talking about here. So let's get into Medicare. We know that Medicare is the federal insurance program for Americans who are above age 65 or if they're disabled. There are 4 parts. So we have Part A Medicare, which is the hospital care. Most people don't pay a premium for that. We have Part B, which is outpatient care. That's like the doctor's office visits. If you have to get x-rays as an outpatient, any ER visits. So most people don't recognize, but there's actually a monthly premium that is involved with Part B Medicare. And for 2021, that amount is $148.50 per month. So I will say that most seniors don't really see this amount because they usually will just take it out of their Social Security checks if they're getting a Social Security check. And then we have Part C, which is the Medicare Advantage plan, also called Managed Medicare. And this functions as a private insurance. And then we have Part D, which is the prescription drug coverage. So right now, if you watch TV at all, you're seeing all of these commercials about Medicare open enrollment. Seniors have to sign up for coverage on a yearly basis, and they get to decide whether they want to keep traditional Medicare, which is Part A and Part B Medicare, and then they can purchase a Part D plan, or if they want to go with a Part C plan that usually has everything kind of all rolled into one. The important thing about the various types of Medicare are that the Type C Medicare can sometimes be a little bit more restrictive. So when you guys are in the hospital and you're rounding on your patients and we're talking about patients needing to go to a skilled nursing facility or go to rehab and all of these things, for patients that have traditional Medicare, like Medicare Part A, Part B, then when we try to get those patients into skilled nursing facilities, it's not as much of a challenge because the skilled nursing facilities know that if they're a Medicare provider, that they don't have to get permission from Medicare to accept those patients. If they meet the criteria, then they're able to go. For patients who have Part C or Medicare Advantage, those are the Humanas, the United Healthcare Completes, WellCare. There are a bunch of different plans. But for those, we have to actually get permission from that health insurance plan for the patients to be able to go to skilled nursing, to go to rehab, pretty much anything that they would need outside of the hospital. So sometimes that usually will take, 24 hours or more to get that approval. Pretty much anything we do, we have to get them to say, yes, we will pay for those services that the patients receive. So open enrollment ends on December 7th. So you'll see a lot more commercials on TV if you watch TV. So then making the transition into Medicaid and CHIP, I bundle those together because they're very similar. So federal and state funded programs, and they're for low income families, individuals, and children in need. These vary according to each state. CHIP is similar to Medicaid, but covers children below the age of 18. And then recipients of CHIP are usually those kids that fall in the gap. So their families make too much money to qualify for Medicaid, but then they don't make quite enough money to purchase that private health insurance. So then making the transition into private health insurance programs. There are a bunch of them. There are a bunch of different types of private health insurances. So this is just like literally the tip of the iceberg. I wanted to give you guys a high level overview and not go into too deep into the weeds. So health maintenance organization, or HMOs, that is a specific type of insurance. The plan requires that you have a primary care doctor, and then you have to have a referral for specialists, and then there's no out-of-network coverage. So they often call this kind of the gatekeeper plan, where everything pretty much goes through the primary care physician. And then when we transition to the preferred provider organization, or the PPO, it's least restrictive. So you can really go to anyone you want. You don't necessarily have to have a primary care physician. You don't need a referral to see a specialist. And you can see people in your network or outside of the network, but understand that the in-network providers are going to be cheaper. And then there are other variations, the exclusive provider organization. It's a mixture of the HMO and the PPO. And the point of service plan, it's also a mixture, but it's more expensive. And it's really like you pick and choose what services you require. So as a result of the Affordable Care Act, they require 10 essential benefits be provided in all private health insurance plans. And those 10 services include outpatient care, ER, hospitalization, pregnancy, maternity, and newborn care, one of the things that's really interesting is before ACA, um, like for example, myself as a woman of childbearing age, I could purchase a health insurance plan that didn't have maternity coverage. Um, and and as a result, that plan was significantly cheaper, probably $200 to $300 a month. You know, I told you guys it was $600 a month for me to have the health insurance plan. Well, if I wanted the plan without pregnancy, maternity, and newborn coverage, then it probably would have cost me about $300. Mental health and substance abuse must be covered, prescription drugs, rehab, laboratory services, preventive and wellness services, and pediatric services. So when we talk about preventive care, there's a host of things here. I won't read all of these from the slide, but you guys can just take a look. Prior to ACA, most of these services were not provided in a health insurance plan. Some of those things we did because it was good patient care, but they weren't always covered by health insurance. So then we talk about the history of managed care. Really, managed care kind of came into existence in 1973 during the Nixon administration. They formed the HMO Act of 1973. Basically, the Nixon administration said we need to do something because there were a lot of supporters to enact a universal health care plan, or like the Medicare for All plan that you hear a lot about in the news today. And basically, they authorized additional funds to assist in and establish expanding of the current HMOs. And it required employers with more than 25 employees to offer a HMO option. And so the thought is that if you have an HMO option, which would be cheaper, of course, than the PPO or the point of service plan that we talked about in a few slides before, then people would want that plan. It would cost less for the companies that were purchasing the health insurance, and then also it would cost less for the consumer. And pretty much managed care was developed because there were spiraling healthcare costs. So prior to the development of managed care, patients would seek care and they would get services done, and hospitals and practices would bill the patients or the health insurance company, and there was no way to really keep a check on those things. So there was no way to say, you know, whether the patient was having the same test done at one hospital and the other hospital. Um, and really now there's not really a way for us to know that very well either. But what happens now is the insurance companies say, well, they had that already, we're not going to pay for it. And so it's not really a discrete activity, but it's a spectrum of activities. And really, managed care was created to manage three aspects: to create cost, that's really the number one thing that they were worried about. They also wanted to manage utilization, meaning how often patients utilize health services, like what was a way to make it more efficient, and then also to improve a way to improve the quality of healthcare services. Because for some reason, the federal government tends to think that as doctors, we just like to do things on patients. And so, really, the quality piece is saying that, okay, doctors just want to do things so that they can bill and make a lot of money. And it's not necessarily what the patients need. And while I think that there are some aspects of that that may be true, I think overall most physicians are not, you know, really performing procedures on patients just to be able to bill. We're doing the things that the patients need. So prior to managed care, we had fee for service, and so that's what I was talking to you guys about before. When you bring in managed care, they may say, okay, well, you have a patient who comes to your office or who is in the hospital and they have this condition. Well, normally before managed care, you may charge $500 for this particular procedure, but managed care says, okay, we'll cover this, but we're not going to pay $500. We'll pay $200. And if you want to be on our plan, then that is the amount of money that you have to accept for this procedure. And then when we transition on to managed care, like I said, that means the insurer allocates a set fee for each person enrolled in the plan. And I'll dive a little bit deeper into that a little bit later. So then transitioning, so what I was talking about before was really private health insurances. So now I'm talking about Medicare. So Medicare passed this prospective payment system because Medicare was also being billed for multiple procedures, and they wanted to figure out a way that they could cap or figure out how to limit the cost to the Medicare program. So in 1982, Congress capped hospital reimbursement rates under the Medicare program. And then the Department of Health and Human Services developed this methodology that's called DRG. Basically, what a DRG is it's an arbitrary number, but there's a set of diagnoses that are included up under this number, and the patient's hospital stay is reimbursed according to that DRG. And I'll also have an example of that later on so you can kind of see a bit more what it means. And this is only applied to inpatient hospital services. And so as a result of this happening back in 1982, of course, hospitals and medical groups expanded outpatient services. So then you started seeing like the outpatient surgery centers, because those are considered outpatient services, um, outpatient therapy centers, and all of those things that were owned by hospitals and health groups. So then we started to see a shift. Since the DRGs were exclusive to Medicare, hospitals and medical groups shifted those unreimbursed costs to private health insurance plans. So then you saw those numbers go way up high. And then employers in return paid higher healthcare premiums so that the people that work for them would be able to have insurance. And so they were trying to control these costs. And thus, you see the improvements and modifications of managed care. So when we talk about managed care, one of the terms that I want to talk about is called capitation. Basically, what capitation means is that there's a fixed amount of money that is per patient per unit of time paid in advance for the delivery of healthcare services. And they put the physician or the health plan or the hospital at financial risk for the care that they provide to the patients. And they utilize their complex formulas used to come up with the cost, the average cost, local cost for patients that are in that area. I'm going to go back to this slide and explain this a little bit more. So a couple of years ago, if a patient was in a capitated plan, what that means is that I'll just say, if there's a senior, they may have said that, okay, we anticipate that for most people in the Memphis area, their healthcare costs are about $8,000 a year. And so the capitated amount that Medicare would pay to, say, Humana, the Humana Medicare Advantage plan, is $8,000 per member that they had in that group. Well, if you can imagine, if that member only goes to the doctor one time a year or twice a year, then they're not going to utilize that $8,000. But then you have some patients that really are admitted to the hospital multiple times, and they're going to use that amount up relatively quickly. And so the goal for these people who decided to take the capitation was to have a good mixture of healthy patients and not so healthy patients, so that that pot of money is not all utilized by the end of the year. So to give you guys an example, so here we have one case, Mr. S, a 70-year-old guy, hypertension, diabetes, heart disease. He takes oral medications. He's never been in the hospital. He goes to the PCP 4 times a year just for his regular maintenance visits, and he gets medications, refills, and labs. So his healthcare costs including medication, is $1,000 a year. So that's not good. That's pretty good. You know, if 8,000 is what you're allocated and he only uses 1,000, then there's $7,000 left over. By contrast, you have Mrs. X, who's a 68-year-old lady, has depression, rheumatoid, diabetes, hypertension. She takes multiple medications, and she was in the hospital 3 times this year for DKA and required a hospital stage time. So her total health care costs were $30,000. Well, clearly that $8,000 that was allocated for her has already been used up. So again, what the health plans really want to do is include multiple healthy patients and then unhealthy patients in that pool. But the way it works is if Medicare agrees to pay um, Humana, $8,000 per member, and they have 1,000 members, and say they have 500 members that are like example one, and then another 500 members that are like example two. I'm not doing math in my head, but they're still going to have a little bit of money left over. And then, so to dive a little bit deeper into this capitation model, they do have different types. So you have an IPA, and when you do that, a lot of physicians kind of assume some of that risk, meaning, okay, I'm Dr. Washington, I have patients who are on this particular plan, say Cigna HealthSpring, and the IPA has agreed to compensate me X number of dollars for this patient's care. Well, I assume responsibility for that, meaning that the pot of money that they gave me may also be involved in other services that the patient receives. So, like if the patient goes to the ER and they don't get admitted to the hospital, well, that's an outpatient service, so it could be potentially part of that. And so it really requires the doctors to really take ownership of the patients. It doesn't really have any consequence for the patient, which is my argument against the capitation model, because sometimes we have patients that aren't really adherent to the treatment recommendations that we have. And so they may go to the ER multiple times, and they could easily kind of eat up the amount of funds that's allocated to them. They have the projected profitability model. That's kind of more complex, where they say, okay, we expect your pool of patients to utilize this much service, and you should have that much profit left over. There's primary and secondary capitations, which we talked about a little bit earlier. So there are pros and cons. The pros are it simplifies bookkeeping. Um, it discourages excessive billing or more costly procedures, and the patients tend to avoid unnecessary tests and procedures. The cons of capitation are that the providers may spend less time per patient, because if you have more patients that are on this capitated plan, then you do have to see them a set amount of times per year. So they may be incentivized to have patients in their office more frequently. And there's also an incentive to providing fewer services. So sometimes the argument is that patients don't actually get the care that they need when they are on a capitated plan. And we always have patients who are exceptions to the rule. They do have adjustments. So if there are certain factors, like if the patients are really old, they do give a modification for female patients. And also, if you're in a region that tends to have a higher incidence of illness, so an area like Memphis, where we have a lot of patients that have diabetes, hypertension, end-stage renal disease, we may get a modification of the payment where it would be higher than, say, someone who was seeing patients in a more affluent area. And then also for patients that have chronic conditions, such as end-stage renal disease and HIV, of course, you understand that those patients utilize more services and will require more care. Okay, so now I'm going to transition over and talk a bit more about hospital-based care. This is more of what I do on a day-to-day basis. So for those of you all who have been in the hospital, you see me on the wards, going to the tempo boards, and I am reviewing the cases on a daily basis, pretty much, of the patients who are in the hospital. One of the things that we have to do is the patients have to be admitted to the appropriate level of care. So essentially, there are two levels of care. There's outpatient or observation, and there's inpatient. So a general overview is outpatient or observation, the care should be expected to be delivered in less than 48 hours. Inpatient is if the care is required more than 2 midnights of hospital care, or if the patient has a severe condition that requires intense treatment. So when we say outpatient or observation care, so pretty much it's for mild conditions or symptoms. One of the rules of thumb is if a patient comes into the hospital with a symptom, but you don't have a diagnosis, then that should pretty much be observation. So chest pain is pretty much always observation unless they rule in for a non-STEMI or STEMI. Abdominal pain with no pathology is pretty much observation. So things like that. If they just come in with nausea, vomiting, then that would be considered observation. And understand that a patient could be observation and they could be anywhere in the hospital. They could be in the ICU. It is about the patient's symptoms or conditions, not necessarily about where they are physically located. So important thing to know is for Medicare, observation is billed under Part B Medicare. And so remember on the previous slide when we talked about Part B, that is the outpatient services side. So that's not free care for the patient. They usually have a responsibility of about whatever their deductible is and 20% coinsurance. And then also, this is one thing that I didn't find out until about a year ago. When Medicare patients are in the hospital under observation status, they actually have to pay separately for any medications that they consider self-administrable. That means any oral medications or creams or anything, like they're paying whatever the hospital rate is for that medication, and that's the bill that they receive. I had no clue about that. And so that's another reason why it's really important that, when you expect the care to go past 48 hours, with a few exceptions, that those patients should be changed to inpatient. Private insurance, they have the out-of-pocket expense that's treated as if you were an outpatient. The plans will differ. Some will say you'll pay 20%. Some will say, you pay the first $1,000, then pay 20% or what have you. When we talk about inpatient care, again, that's determined by assessing the severity of illness and the intensity of treatment. It also talks about the medical probability of an adverse event. We expect that hospital care to be more than 2 midnights. For Medicare patients or patients that have managed Medicare or a Medicare Part C plan or Medicare Advantage plan, all of those patients have to have 3 medically necessary inpatient midnights of care to be able to qualify to go to a skilled nursing facility. I know sometimes you guys hear the case managers talk about that, oh, they need 3 midnights to be able to go to a skilled nursing facility. And then also there are some procedures, like some surgical procedures, that are considered inpatient only procedures. So regardless of whether the patient stays in the hospital 2 midnights or not, Medicare has recognized that these procedures have enough complexity and that the patient should be classified as inpatient, regardless of how long they stay in the hospital. And if you guys have questions, feel free to chime in. I'm happy to explain things a bit more in detail. When we talk about special considerations, one of the things that we talk about, and St. Francis with the EHR has really made it a bit easier, is that there must be an order put in requesting outpatient or observation services or inpatient status. Now, our Cerner won't let us go past a certain step before we put those orders in, so we don't really have an issue with that. But understand that not all facilities have that kind of hard stop. And then if the patient is requiring inpatient status, then there also has to be a statement saying the expectation of at least 2 midnights hospital stay. Again, this is already programmed for us in Cerner. When we put in the inpatient order, then it says, do you expect the patient to have 2 midnights? And you say yes. For Medicare patients, there's a rule that's called Condition Code 44. And so what that means is that if a patient got admitted to inpatient, and I review the chart or somebody else reviews the chart and say, oh, I really think they shouldn't have been an inpatient. They probably should be obs. Then you have to do a condition code 44. And that's a specific protocol. The reason for that is kind of going back to what I said before about the observation status and that the patients have a 20% co-insurance that they have to pay and the carve out for the medications and testing. Medicare says it's important that you let the seniors that are in the hospital know that that's actually what will be required of them. So there's a statement that they have to receive, they have to sign a form to say that they understand that. And then Medicare has also enacted that there is no payment if the patient is rehospitalized within 30 days. And so that is another thing that you guys will likely hear at the Tempo board. Oh, this patient is a 30-day readmit. And basically, what that means is the care that that patient is receiving during that time is usually bundled in their prior hospital stay, and the hospital doesn't get any additional revenue for the care that they're providing for that patient during the new hospital stay. So, when we talk about level of care, one of the ways that you guys should think about doing this when you're seeing the patient, saying, we talked about a little bit earlier, is this presenting condition a symptom or a diagnosis? Is the patient likely to improve to discharge in less than 48 hours? Is the patient having a procedure or a surgery that's on the inpatient only list? And did the patient require pre-certification prior to the admission? So the first two things we talked about briefly before, if the patient's having a procedure or surgery that's on the inpatient only list, usually the hospital already knows that. They have someone that kind of works on the back end and billing that will know whether that patient's surgery is on the inpatient only list. So in general, that only applies to the surgeons. And then also, did the patient require pre-certification prior to the admission? For most patients who have private health insurance plans, if they're coming to the hospital for something that is previously scheduled, for you guys, I think mainly that would be like a hysterectomy or something like that. Those patients have to get pre-certed before they come to the hospital, and then that's whatever the insurance company says. If they say, okay, I think Miss X that's getting a partial hysterectomy needs to be observation. So at that time, then it's important that that patient is admitted to the level of care for which he or she was pre-certed. If not, the insurance company doesn't pay at all. And then there are a lot of clinical decision tools that I had no clue about before I took this physician advisor job. There's guidelines called Interqual and MCG, but when the case managers call you, or if I call you and say, hey, this patient doesn't meet criteria, then these are the criteria that we are utilizing. So Medicare doesn't really require the use of either of these guidelines, but the various hospital systems utilize it so that they can say, well, there was some standard that we utilize to determine whether that patient required inpatient care or did not meet inpatient criteria. For St. Francis, they use Interqual. Private insurance companies will utilize either Interqual or MCG. And private insurers can approve or deny patients based on the clinical documentation available in conjunction with the guidelines. So I've been talking a lot about observation care and If we expect for them to be in the hospital for less than 48 hours, then they should be observation. Really, for the private health insurances, all bets are off. There are times when there are patients who are in the hospital and they can be in the hospital for 6 or 7 days. If they review the criteria and they review the documentation, they'll say, well, you guys didn't really do a whole lot other than get a patient some IV fluids and some IV antibiotics, but the patient was stable. We're not going to approve inpatient. We're only going to approve observation. Um, so you guys say, well, what's the big deal with that? Who cares if they'll only pay observation versus inpatient? If they deny inpatient status on a patient and we have the patient listed here in our system as inpatient, then if there's a discrepancy, then that means the insurance company doesn't pay the hospital for those services that are provided. If we review the case and we think that the patient does indeed meet inpatient criteria, then that's when we go to that peer-to-peer. And so I am on the phone with insurance company medical directors daily to get these cases approved. We get multiple, like at least 20 to 30 insurance denials per day in the hospital. So I'm talking to them all the time. Again, we talked about before that observation affects the patient's financial obligations. We know that most managed care payers pay for 1 or 2 observation days. Just to give you a little bit of insight and numbers, the Medicare observation rate for 2020 is $2,203, meaning that's the payment for the entire stay, regardless of the services that are provided and regardless of how long the patient stays. So if that patient is in observation status and they stay for 1 day, the payment is $2,203. If they stay for 10 days and they're in observation, that payment is also $2,203. And also the numbers are a little bit different. The private insurance companies reimburse different amounts, but it's still a similar type thing. They may say, oh, Blue Cross Blue Shield may say, oh, we only approve observation. And when they approve observation, then what the hospital receives is the observation rate.
I have a question.
Yes.
And it's the admission status after the patient get discharged that counts. Because I know sometimes, they'll call us to switch them to inpatient or switch to observation. It's like the final discharge. Right. Okay.
Right. It is the final. That's a great question. So, what the insurance companies don't like and what we tend to get into some audits. So as soon as you recognize that the patient will meet inpatient criteria, then it's important that that patient be changed to inpatient, because they kind of frown upon if you enter the inpatient order at 9:15 and then at 9:20 you enter the discharge order. They feel like somebody's trying to get over on them. However, by the same token, if you have the patient listed as inpatient, I call and I say, hey, the patient doesn't meet inpatient criteria. Can you change the patient to observation before you discharge them? It's very important that that observation order goes in before the discharge order goes in, because the kickback is that the hospital won't get paid at all. So a few level of care pearls. This is kind of reiterating the things that I talked about before. Make sure you place them in the appropriate level of care. Elective surgeries have to be placed in the level of care for which they were pre-certed. And then documentations should support your level of care. So this is something that's a little bit different than the way that we usually document in our progress notes. So if I call you and I say, hey, based on, your documentation or based on my review of the chart, I don't think the patient meets inpatient criteria, you can say, well, I think the patient meets inpatient because they have this, and this, and that makes them at risk for an adverse outcome. Well, if you document that, then that is the argument that I will use, and the documentation that's sent to the insurance company medical directors. And then they would be more likely to overturn the case. Still, sometimes, even with your um, statement stating the risk, still sometimes they won't um, approve the inpatient for those patients. A couple other things. So they have a lot of procedures that were recently removed from the Medicare inpatient only list. And so you guys don't see a lot of the ortho procedures, but a lot of those were taken off recently. So knee replacements, hip replacements, most ortho procedures are not considered inpatient anymore. And that doesn't mean that they can't be inpatients if they come in. It just means that what we document has to justify why we think those patients need to be inpatient. So say there's a patient who comes in who needs to have a knee replacement. I may see that patient and say, I'm looking at the patient. She's got poorly controlled diabetes. She's got sleep apnea. She's morbidly obese. Well, all of those things are risk that could potentially cause an adverse outcome for this patient post-operatively. So it's important that I document in the initial H&P and say, hey, this patient has all of these comorbidities and it makes them increased risk for an adverse event post-operatively. Then I can say, well, I'll admit that patient as an inpatient. And if that patient has private insurance, then it's important that I make that statement before, like when I'm seeing them in the office, so that I can get the pre-cert approved for inpatient. And pretty much whatever Medicare does, then the private health insurances do later on. So once Medicare took the hip replacement, knee replacements off inpatient only list, then that also means that the private insurances take it off too. Often, when they take those procedures off the inpatient only list, it means also that the amount of money that they pay the hospital and the doctor for those procedures go down. I get calls all the time. I get denials all the time for patients who have had surgery and the procedure wasn't pre-certed. And often I'm arguing with the medical directors, but pretty much the rule of thumb is if they didn't pre-cert the procedure, then you don't get paid. And then also sometimes, so for you guys, we actually have different billing. So the hospital does billing and then the physician services do billing. One of the new things is that if the hospital billing and physician billing don't match, meaning if the hospital and the computer, we say that the patient is observation, but then on the physician side, when you're doing your progress notes, you're doing your billing for the day. If you say, what did I say here? If we say the patient's observation in the hospital, and then you say the patient is inpatient on your hospital billing, they're gonna say, oh, there's a discrepancy, so nobody gets paid. Like if there's an error, nobody gets paid. Then we get to the peer-to-peer discussions. Like I said, I talk to these people all the time. There are some insurance companies that will only talk to the attendings or a physician that's directly involved with caring for the patient. Those discussions should never be declined because it can really make a huge difference in the reimbursement that is obtained for that patient's care. And again, always document why your patient needs to stay in the hospital. So then we talk about the clinical documentation improvement. Do you guys as residents, do y'all get queries or do they only query your attendings?
The attending, it comes on a chart. We can see it as well, but the attending has to take care of it.
Okay. So the queries aren't really going anywhere. So you guys will be affected by it at some point. But it's really, it's very important that the clinical documentation be complete. So that's the way that as clinicians, we communicate with each other. I know sometimes people don't always pick up the phone and call the consultants. That is one thing that I think since I started my medical career, we would always call all of our consultants and discuss the cases with them directly. That's one thing I don't like about this new age medicine. Because I think that a lot of things can be lost in translation and not everyone is the best documenter. But your clinical documentation is used by a lot of different people. So coding, patients, patients with the new government requirement, patients have to have access to their medical records. It's used by state and federal agencies and, of course, insurance companies. It impacts the quality of care. It impacts physician and facility reimbursement. There are a couple of topics that we're not going to dive deep into, but value-based purchasing and quality measures. We have here in the hospital the core measures, and they talk about how they want you to utilize order sets. And basically what that means is Medicare or the government has made requirements saying that, all patients that have heart failure need to be on an ACE inhibitor, a beta blocker. We have to document that within a certain point in time. All patients with AMI have to be on an aspirin, a statin. Like, we have to have those things documented. And those are the quality measures. So if it's in your note, then that's how they know that you did that thing. And then also for medical legal purposes, hopefully you guys will not have to experience that side of healthcare ever, but there is a chance that you will. And so it's important to appropriately document, because we see so many patients on a day-to-day basis that there's no way you can remember specifically what you did during that particular patient encounter.
I think also I've seen it for systolic, like heart failure, when you're discharging the patient. If they're not on the right medication, you'll get the alert to say, hey, you documented the EF as this, and you're required to add certain medications. So that's the only one I've seen it for. I don't know if they have it for other diagnoses.
Yeah, the heart failure one is I think the one that's more utilized. So we see that one frequently. But then, we also have, sometimes the nurses will call you and say, hey, this is a stroke patient. They're not on a statin. They're not on an aspirin. Can we add that? So the nursing staff also has different check marks that they have to utilize to go through for the ones that aren't plugged into the Cerner system. Okay. So we'll talk about this case, and it's a little bit busy, so I apologize for that. I think it's the font that I chose here. And then we'll talk a bit more about like the DRG and how documentation really will affect the reimbursement. So we have this case, this patient, 86 years old, with diabetes, hypertension, hyperlipidemia, coronary artery disease. He was found down at home. His temp was 104, pulse was 105. Respiratory rate, that should be respiratory rate, was 8. Blood pressure 76 over 50, and O2 set was 87% on non-rebreather. So pretty much, this guy is sick. White count 42,000, BUN elevated, creatinine elevated. He's got a UTI, and his blood culture's already grown out gram-negative rods in less than 24 hours. And so the treatment he got 3 liters normal saline. Then his blood pressure was still low. They had to put him on Levophed. They put him on IV vancomycin and cefepime. He got intubated and was placed on the vent. So these are the diagnoses that were documented: UTI, respiratory distress, type 2 diabetes, and bacteremia, which is true. But these diagnoses by themselves don't really reflect how critically ill the patient is. And so with these diagnoses, it would be a DRG of 690. And for that DRG, the total payment for this patient is $4,170. And then the GMLOS is basically, they pulled all the patients with this 690 DRG, and they say, how long do we anticipate that these patients need to stay in the hospital? And they give an allocation. And so the expected length of stay for this patient is 3.5 days, right?
Yeah.
Based on the diagnoses that we provided. But I think that all of you guys can recognize that this guy is probably going to need to be in the hospital for longer than 3.5 days. So what should have been documented? So what should have been documented is sepsis with septic shock due to gram-negative organism, acute respiratory failure. You could add requiring mechanical ventilation, acute renal failure secondary to ATN, metabolic encephalopathy, because he was found down and unresponsive, a UTI, and then type 2 diabetes. So that changes the DRG to 871, and then that reimbursement goes up to $10,022, and they give you 5.5 days to care for this patient. So that's a huge difference. And the only difference is we still care for the patient in the same way, we just document it differently. And so that's what improvements in your clinical documentation can do. So we talk a bit more about that, once you guys get out of residency, you'll be more concerned about this, but they do have what they call preferred provider status for doctors. And basically what that means is they compare you to other doctors who take care of patients that have the same DRG. So if you got Doc X and Doc Y, the patients both have the same DRG. The expected length of stay is 3.2 days. Well, one doc cares for his patients and they get out of the hospital in 2.5 days. The other doc cares for the patient and they get out of the hospital in 5.5 days. Remember, the estimated length of stay for this patient was 3.2 days. So then you say, well, who is the rock star? Well, of course, the insurance company is going to recognize the doctor that kept the patient in the hospital for the shorter period of time. And then they say, well, he's a preferred provider. And they increase the reimbursement by 10%. Whereas the one who had the patient in the hospital for a longer period of time said, well, now you're not on our preferred provider list. And as a result of that, your reimbursement is decreased by 20%. So it really does have an effect on what we do from day to day.
I have a question.
Yes.
Do they take into effect readmission rate between those two providers, like from the hospital discharge?
Right. So for the readmission rates, the thing about that is it's really, the readmissions really affect the hospital more, and it doesn't really affect the physician more. So sometimes the physicians that are working independently don't really feel the weight that, okay, I have a high readmission rate, but I'm getting my patients out of the hospital, because they're still billing the patients for those physician services. But the hospital is the one that's not getting paid. So when we say, what can physicians do? Like, what can we do to try to combat this? Number one, accurate documentation, making sure that you respond to queries in a timely fashion. You guys see the queries that are in the chart. Most of the time when the CDIs do a query, it will add complexity to the patient. So most of the time they're asking for clarification. I know one of the things that's new that they've been doing more queries about is renal failure. Like, stage 2, 3, 4, you have to put actually like what you think it is due to. That's a new requirement that's come up really since COVID, that they're querying more about. You see a lot of heart failure queries. So make sure if you see those, make sure you alert your attending so that they can complete those in a timely fashion. I'll also say that, when we get those queries that are unspecified, or you say, I don't know, most of the time it is a way that we can figure out that. And like I said, it will really affect that patient's reimbursement rate, and also how many days it's allocated for the patient's care to be provided. Another thing we can do is communicate with the consultants to determine the plan of care. I see that a lot on the patient's charts, well, waiting on, this consultant to determine, if the patient can discharge. And so really that's a conversation that can occur between physicians. Is really important to do that and say, hey, what do you think about this patient? Do you think they need a heart cath before they leave? Do you think they need an EGD? Do they need these things, or can they be done as an outpatient? That will really affect, and also being able to adequately reflect that and document that in your progress note. And then it's important to think about discharge planning at the time of admission. Um, there are often times when we see patients, we're admitting patients from the ER, and we can look at that patient and tell that they're not going to be able to go home. So if we think those patients need to go to rehab or skilled nursing, it's important to think about that right off. Or if that patient lives alone and will need more services, all of those things are very important to really document in your initial H&P, so that the case managers can really get on top of that. Even if you know that, when you're admitting the patient, you can put in a case management console and say that that patient's going to need placement, really at the same time you do the admission orders. And that can be very helpful, particularly now that we're in COVID times, where every patient that leaves this building and doesn't go home, so if they go anywhere else, skilled nursing, rehab, LTAC, inpatient psych, those patients have to have a COVID test, which is going to take at least 24 hours to get. So if you think they may need to go to one of those places, then it's important that we know early. And then, so what can hospitals do? They can assign the appropriate DRG. They can provide services in a timely manner. Sometimes we get frustrated. We just came off Thanksgiving. I know there were a lot of patients that were here over the holiday weekend that were just waiting for a stress test or waiting for an EEG or something like that, those services that we don't really provide over the weekends and the holidays. And that can add time. And then also to respond to denials, that's more on a case management, utilization management thing. Like I said, I get these notices on a daily basis and I respond to them on the same day. Okay, I know that this patient's care got denied. So I'm on the phone, I'm calling you guys. If you see my number, please answer. To say, hey, they denied, what's going on with the patient? Tell me why you think they need to stay, or is there something that we can do to help get the patient to the point that they're ready for discharge. So closing out, to give us take-home points, healthcare is ever changing. Pretty much every year there's something new that goes on with this clinical documentation, that goes on with how hospitals are being reimbursed. It's important to stay up to date on those trends. It's important to accurately document the diagnosis, condition, risk, and concerns, and understand that what you document can really affect the physician and the hospital revenue. Also, the insurance companies and Medicare overall use this to grade the quality of physicians, medical groups, and hospital systems. And like I said, as we showed before, it really can affect the revenue that's for the hospital. A lot of people talk about, oh, well, the hospital gets a lot of money. Well, the hospital has a lot of patients as well. And when we think about that, really now, if we think about it here during the time of COVID, we think about St. Francis. This is a huge hospital facility with a bunch of beds, but we have whole floors that are not functional at this time because we don't have staff to be able to do that. And that could be because there's no revenue to be able to cover those staff. So the way that the hospital makes money is by taking care of patients, whether that's in the hospital or them coming in to get outpatient services. All of it kind of works together and trickles down to really make a big difference in what we do from a day-to-day standpoint. Any questions at all?
No, I think you answered them.
Okay. Well,
just curious, since you mentioned COVID testing, was there a conversation about doing universal COVID screening for patients in the hospital, and is that going to be a thing?
There was a conversation. There have actually been multiple conversations about that. I was a fan of universal COVID testing since we first found out about COVID, and that I don't make those decisions, unfortunately. And that was not something that they were wanting to do at this time. But I do feel like all patients that come through the door should have COVID testing. But they don't pay me for that.
Man, even when you're high up there, it's still that same frustrating thing, huh?
I'm not that high.
Okay. Thanks, Dr. Washington.
Yeah. And then I put my contact information here, my tenant email, my cell number. You guys can call or text me anytime. If y'all have any questions or concerns, please let me know. I hope y'all found that this was helpful. I think that it is a good overview to kind of understand a little bit about the business aspect of medicine and what needs to happen, and how you guys really can affect the business aspect. And then if y'all have any other questions about what I do, don't hesitate to reach out to me. For background, I practiced hospital medicine for 10 years. Before transitioning into this physician advisor role. I still do have a small outpatient practice, but I decided to get an MBA and wanted to try to make a difference kind of from an administrative aspect, and continuing to work hard on that and try to work my way up in the system.
Thank
All right,
you.
sorry, I know I went over for a few minutes, but you guys take care and have a good afternoon.